Assalamu alaikum and good evening, everyone. Thank you so much for coming. I welcome you all to this Midsummer Endocrine Conference 2025 Bourbon. We are gathered here today for a corporate symposium by Martin Doe Pharmaceutical Company. For today's talk, we are having a speaker, Dr. Mohammed Sohail Anjum. Dr. Mohammed Sohail Anjum is consultant endocrinologist and diabetologist. For the talk, we have a worthy panelist list. Professor Dr. Arshad Hussain, who is working as consultant endocrinologist in Northwest School of Medicine, Northwest General Hospital. Dr. Faisal Masood Qureshi, who is a consultant endocrinologist, and Dr. Shahbaz Qureshi, who is consultant cardiologist. So I'm inviting our worthy speaker, Mohammed Sohail Anjum. Before starting the session, we will listen to a few verses of the Holy Quran. So kindly have in pay respect to the few verses of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Jazakallah. We are having our panelist here. I would like to invite our panelist, Dr. Faisal Muhammad Qureshi. Please, sir, join us on stage as chair and panelist. Dr. Shahbaz Qureshi, consultant cardiologist. Sir, please join us on stage as a panelist. We are waiting for Professor Dr. Arshad Hussain. He will be joining us soon. Now I would like to invite our speaker, Dr. Mohammed Sohail Anjum, who is consultant endocrinologist and diabetologist. Sir, please come on stage and enlighten us with your talk.
Bismillahirrahmanirrahim. Thank you very much. I want to extend my gratitude to Pakistan Endocrine Society for organizing such a wonderful event at a very pleasant venue. I would like to extend my gratitude to Martin Pharma as well for organizing such a wonderful session. And I welcome you all as always when before and love to have you in future as well. Today we are going to discuss few guidelines in the management of diabetes and the current approach, few trials, and how the recent inventions and research has changed our approach towards management of diabetes. It is nowadays, it is not only the numbers, not only we need to control diabetes, we also need to use those drugs which are very useful in lowering overall cardiovascular morbidity and mortality. Diabetes, unfortunately, has become a pandemic. If we see the global population burden is about 8.2 billion people, and among those adults, we can see there about 537 or more millions are suffering from this menace. Unfortunately, there is a huge number of patients which are diagnosed. The people with carrying with pre-diabetes, with the birth defects, patient with impaired fasting. I think the burden is much more than we anticipated. And as the number is increasing, similarly, our expenditure on health is increasing. It is not only the control of disease important, also the primordial and primary prevention is equally important. Pakistan is no different than rest of the world. We are unfortunately among the top leading country in prevalence of diabetes and unfortunately in hypertension as well. We are carrying one of the highest prevalence of diabetes, around 30 to 33%, whereas the global prevalence is somewhere around 12 to 18%, depending on areas. If you see the USA diabetes burden, recently there is a huge number of patients which are currently undiagnosed in a very well-developed country. The number is about 9.7 million and 29.3 millions are diagnosed with diabetes, and there is a huge burden of patients. About 115 to 116 million have pre-diabetes. This is, a country where the resources are abundant, diagnosis is frequent, and the general populace is much more aware. In that population, there is a huge number of patient burden which is undiagnosed. So what about in our country where resources are limited access to the medical field and also the ignorance level? I think our number is much more. About 75% of patients suffering from diabetes, unfortunately, are currently undiagnosed in our country. There are many factors. Unfortunately, Punjab and Sindh is one of the worst areas, also the most populated one. Growing age, family history, hypertension, obesity, sedentary lifestyle, high carb intake, and a lack of access to the medical sources, one of the leading factors in developing diabetes in our country. If you see about 2 million to 20 years before, one of the major causes were stroke, hypertension, cancer, but recently the data showed that most of the deaths are attributed to the diabetes or diabetes-related complications, unfortunately. About 2 decades before, diabetes was nowhere among the top 10 leading causes of death. But unfortunately, it is number 5 or number 6 now, and rapidly replacing and coming in number 3 or number 4. The causes of deaths in patients with type 2 diabetes, it is the cardiovascular, the cause, which is about 66% patients are dying in diabetes due to the coronary heart disease. And nowadays, every day you are seeing sudden cardiac deaths, especially in young adults with diabetes, unfortunately, is much more common, and it is contributing about 30.1%, whereas the remaining 33% are due to the non-vascular causes from diabetes. So the overall cardiovascular risk is not less than 2 to 4% times than the same population without diabetes. So diabetes, unfortunately, is one of the leading cause, not only in cardiovascular deaths, but also in CKD. About those patients suffering from CKD, 25% they have diabetes, and only 5.3% have non-diabetes. So it is about 4 to 5 times more number of patients with diabetes are developing not only CKD, but also patients suffering with severe kidney disease, severe renal impairment, with a eGFR less than 30. Their ratio is 3 to 4 times more with diabetes. If your patient is suffering from diabetes, their chances of having end-stage renal disease and ending with dialysis is about 3 to 4 times more than those patients do not have diabetes. So it is a disease which should not be ignored in any way. And not only we need to increase our awareness about these prevalent complications, we also need to use those drugs to control diabetes, which will lower the overall cardiovascular risk, overall risk of CKD, and overall all-cause mortality. So what are those agents? One of the most significant agent after years of research, it was a sodium glucose cotransport inhibitor. If you see the mechanism, about 90% of these receptors are in proximal tubule, about 10% are in the distal tubule. If the drug works on that, that will lead to the selective inhibition of the resorption of the glucose, leading to artificial glycouric effect. One of the drug which is a winner is empagliflozin. As we have seen in 2014 EMPA-REG trials, it marvelously showed a significant improvement in lowering cardiovascular morbidity and mortality. And my university in Europe was one of the trial centers for this one, and also for Canvas trials. In the middle of the trials in 2014, canagliflozin was found to increase amputation. And then we also analyze all of our patients on empagliflozin to see that is it due to drug effect or a class effect. But fortunately, most of our patients which were on empagliflozin during that time, the number was in hundreds. It did not significantly show any significant increase in risk of peripheral vascular disease or a large limb amputation. So it was most likely a drug effect rather than a class effect. So what are the key benefits of using SGLT2 inhibitors? We will see there, it is not only a glycouric effect because it leads to glucose depletion. So the alternative mechanism is activated, and with the use of fat metabolism, free fatty acids, and with increase of beta hydroxybutyrate, overall the cardiac activity does improve, and also the visceral fat also depleted, and the overall quantity is reduced with the use of SGLT2 inhibitors. This is not seen with other drugs except GLP-1 analogs, but this drug is more prominent in lowering the epicardial or pericardial fatty tissue as compared to with the GLP-1 analogs. It also reduce the preload and afterload, and we will discuss these effects in detail, how the SGLT2 inhibitors lead to increased diuresis, natriuresis, and afterload reduction. It is the afferent vasodilation and efferent vasoconstriction which leads to the increased glomerular pressure and subsequently the increased glucose threshold. And then with the blockage of the receptors which leads to absorption of glucose, overall there is a significant amount of glucose left behind to be excreted through urine. So that leads to volume depletion. Overall, there is improvement in systolic blood pressure, in diastolic blood pressure, in reducing the left ventricular stress wall. So what about the CKD in patients with type 2 diabetes? The overall global prevalence is huge. About the number is surely more than 42 crore patients with diabetes now. Every month number is ever increasing, quadrupling even in a decade time, unfortunately. And the CKD patients are about 60 crore patients with 42 crore diabetic burden. It is something which cannot be ignored. So the overall 38% patients are suffering from this disease. And as we already know, that the cardiovascular risk is about 2 to 3 times, in some studies 3 to 4 times more. If we add on with diabetes, so the overall risk is much more higher. And the age is about reduced about 16 years. In our country also, the average is not so huge. And if we take out 16 years out of it, I think it is a number which is not feasible and appreciable for all of us. So the effect of diabetes in patients with heart failure, even non-diabetic patients with preserved ejection fraction do perform better than patients with diabetes with a low ejection fraction. So overall, if the patient has diabetes, their chances of developing cardiovascular deaths are much more than if they do not have diabetes. So overall percentage is not less than 57%. Any patient you are seeing with heart failure, in next 5 years, many of those patients you are not going to see in your clinic because of the progressive kind of nature, recurrent admissions, and each time deterioration of myocardium, the risk of cardiovascular death after developing heart failure, especially with the low ejection fraction, is tremendously high. So whenever you are going to see your patient with the heart failure, even with preserved ejection fraction, please give an utmost importance to use not only those drugs to lower the A1C level, to lower the weight, but also those drugs which are very useful in lowering the 3-point MACE. EMPA-RAGE trial showed that the 3-point MACE is reduced about 14% as compared to with the other agents, with the standard of care treatment. Cardiovascular deaths about reduced by 38%, heart failure 35%, and all-cause mortality about 32%. It was many years of research. No drug was so evident in reducing the cardiovascular morbidity and mortality where the preserved ejection fraction, heart failure was a concern. ARNI was deeply studied, but unfortunately, the trial didn't conclusive about those patients with preserved ejection fraction. So one of the major drug which is even in non-diabetic patients is SGLT2 inhibitors. If you use this drug, even without diabetes, your patient is going to enjoy the benefits of prolonged survival due to the less cardiovascular events. So it reduces about 27% if ejection fraction is more than 40%, and the cardiovascular events reduced by 30% if ejection fraction is less than 40%. So it is extremely important with low ejection fraction, but with preserved ejection fraction, this is becoming the drug of choice for many of the cardiologists. So EMPRISE trial showed that if we compared it with the GLP in a heart failure patients, the reduction is about 32% more in SGLT2 patients as compared with GLP, 30% with DPP4, and 18 and all-cause mortality reduced about 45% as compared to with the DPP4. So SGLT2 inhibitors are really impressive, and they have a multiple effects. They have an increased metabolic efficacy, osmotic diuresis, and reduced blood pressure. And somebody did a very good trial. This is very important, that empagliflozin in patients hospitalized for acute heart failure. They always look that is this drug causing or worsening any more of ejection fraction or cardiac morbidity and mortality, as we have seen in DIGAMI-1 trials where insulin was studied. Initially it was found to be useful, but after 2 years when a prolonged trial was done, it was found out that the early insulinization in patient with acute MI actually does increase the cardiac morbidity and mortality. But this drug is actually a bit different. Those patients with established cardiac failure, meaning that increased pro-BNP or BNP simple, they did a 90 days follow-up trial, and even 90 days are not enough to see the efficacy of that drug, but the premature results showed that the all-cause mortality reduced about 4.2% as compared with 8.3% with placebo or with standard of care. So this is a very important. And empagliflozin with acute MI patients, it is quite safe. The trial showed that if we use it at an earlier stage, in about 26 weeks time, it reduced the pro-BNP level. So it has quite a very good effects on cardiac remodeling. Heart failure are reduced about 35% relative risk reduction as shown in EMPA-RAGE trials. Canvas trials with canagliflozin 33% reduction. Declare TIMI with DAPA showed 27%. So overall, among these SGLT2 inhibitors, although it has some sort of class effect on reducing heart failure, but the empagliflozin seems to be a bit more potent than other competitors of the same group. So it is overall associated with the all reduced hospitalization, reduced cost, and all-cause mortality. And when the EMPA kidney trials appeared, and they showed that 28% reduction in progression of kidney disease, those patients on SGLT2 inhibitors, their doubling time of eGFR is much more longer than those patients who are not on SGLT2. So those patients are going to suffer with less deterioration of renal functions if they are not on SGLT2. Initially, you might see some 5 to 10% decline in GFR, which usually settle down in about 4 to 6 weeks time, but there is no clear guidelines. But I think the guidelines are the same, like ACE inhibitors, ARBs. If you are seeing worsening of 25% eGFR within 4 to 6 weeks time, you might reconsider your approach of starting that. Otherwise, within that limit, please continue. Start with a low dose, go slow, and then build up depending on monitoring of your renal functions. So this is very important asset study. This study has actually emphasized different aspects of cardiac remodeling. And this is the first study which showed that the cardiac fat accumulation, cardiac function, and cardiac metabolism is really associated with early onset of diabetes. If your patient is having early onset of diabetes, meaning less than 5 years, if you start this drug, you reduce their fat burden, reduce their BMI, so their epicardial and pericardial fatty tissue is going to reduce. So overall, what we see, the cardiac remodeling is achieved with this magnificent drug. So what about the epicardial fat? It leads to abdominal obesity, elevated blood pressure, impaired fasting, and dyslipidemia. All this constellation leads to metabolic syndrome. So the myocardial triglyceride content is directly related to the free fatty acids. Higher the myocardial triglyceride, higher the free fatty acids, and leading to the cardiac toxicity. So a thin lean patient, if compared with type 2 patients, we can clearly see the fat content is much more higher as compared to water with patients with type 2 diabetes and impaired glucose tolerance test. So we should focus on this aspect as well. It will overall reduce the cardiac morbidity and mortality due to the remodeling effect and depletion of the pericardial excessive fat tissue. So overall, if we compare empagliflozin with sitagliptin in 12 weeks time, we can clearly see there is a good change in reducing plasma level, 5.3 with sitagliptin and 31 with empagliflozin, and plasma insulin is not statistically, is impaired with SGLT2 inhibitors, and it's actually the sensitivity is improved as compared to with the sitagliptin. And what about the body weight? In empagliflozin, the weight reduces significant from baseline 1.2 kilo as compared to with the sitagliptin, which is relatively weight neutral. And A1C reduction is almost comparable because it is a short study. If we use it for a longer duration, about 3 to 6 months, then we can appreciate that HbA1c reduction of more than 1.1%. So from liver back to the liver, because the SGLT2 inhibitors leading to the elevated concentrations of ApoA1 and apocrine, the component of the fat A2 is associated with a lower risk of cardiovascular risk. So the merely 5 milligram reduction in HDL leads to 25% increased risk of myocardial infarction. So always take HDL in your lipid profile, very important, because it is going to overall increase the lifelong risk of your patient. So this study also showed that ketones, beta hydroxybutyric acid, is actually working as an energy for the myocardial, where many tissues are not feeling comfortable with the increased level of free fatty acids and with the beta oxybutyrate, but the cardiac tissue behaves differently. It serves as an energy pump. If given in a small amount, then its toxic effect is negated, and it leads to the resorption of the fat as compared to those patients which are not on SGLT2 inhibitors. And this study has actually come out recently, and it showed that the cardiac remodeling is very important, and the small dose which is being produced with the SGLT2 inhibitors, a small dose of beta hydroxybutyrate actually works as an energy stimulator for myocardial tissue. But this should be carefully monitored, because if we keep the ketones below 0.6 millimole, that is desirable. If it becomes between 0.6 to 2.6, then many tissues do not behave reasonably. The patient is dehydrated, and alternative fatty metabolism is unfortunately doing worse than the beneficial effect. If it is more than 3.5, obviously it is DKA and need admission. Empagliflozin is very useful in lowering HbA1c level in almost all those patients with lower GFR, even with class 3, with class 4, and it should be avoided in class 5 patients, with those patients with eGFR less than 20, until a person who is highly expert in that field, who has a substantial number of those patients with the close association with nephrologist, might take their own personal decision, but guidelines suggest that if it is below 20, need to avoid that until patients on dialysis or not. So cardiovascular and renal outcome with empagliflozin, we have seen that there is a 25% improvement if patient is taking empagliflozin, and about 30% improvement in heart failure, which is very important because the more hospitalization and admissions, the hospital cost of the patient does increase. Also, the cardiac morbidity and mortality does increase. So the hospitalization for heart failure are reduced by about 30% if the patients are taking empagliflozin. This is very important. And overall, because of lack of time, we will skip. I will try to complete in time. So deaths from the cardiovascular risk, about 38% reduction with empagliflozin as compared to with the placebo. I don't think there is any other drug which is near to that. Even A1C reduction of 1% is going to reduce about 14 to 21%. So this is an add-on effect other than HbA1c effect. So this is a drug which should not be ignored in our daily practices. So the hospitalization, SGLT2, overall their effects are diuretic effects, glycouric effects, and erythropoietin increase effects, and decrease left ventricular mass, and also reduce vascular stiffness due to that. So what about combination? We know that DPP-4 inhibitors are very good. They increase the GLP concentration about 20 to 30%, whereas the GLP-1 analogs, they do increase from 100 to 300%. So the higher the level of GLP, higher its incretin effects. So if we compare it with the other DPP-4 inhibitors, we don't need to reduce the dose of linagliptin, which is very renal protective. Because it's a biliary excretion, so no need to worry about the dose. Most of our patients with diabetes, they have some sort of kidney disease once they are diagnosed, where in our part of the world, the follow-up is not so great. So we need to use that drug, which is less nephrotoxic and requiring less monitoring of renal function. So if we need to add on DPP-4 inhibitors, one of the choices linagliptin. The trial showed that linagliptin is excellent as compared to with other drugs. A Carmelina trial was a landmark. It showed that there is no statistically increased risk of 3-point MACE. So there is no worsening of renal failure, there is no worsening of hospitalization, there is no worsening of non-fatal MI, non-fatal stroke, and mortality due to the cardiac event. So it is very safe. Then another trial, Carolina, showed if it is compared with the glimepiride, it is the same effect, not only in lowering HbA1c, but also similar cardiovascular outcome without increase in weight and severe hypoglycemia, which is sometimes associated with glimepiride. So overall, if we see the cardiac, overall the summary, it is very safe drug, and it doesn't worsen heart failure. It has neutral effect as like other DPP-4 inhibitors. So if we have to combine SGLT2 inhibitors with some DPP-4, linagliptin is one of the choice in those patients where the renal the safety is questionable. It's not as potent as sitagliptin. It is about 80% as potent as sitagliptin, as many trials showed that, but it is much more safe. Also, we should not neglect the use of metformin. all the guidelines, they have showed that if there is no compelling contraindication to the use of metformin, the patient should continue enjoying the benefits of metformin. The other point I want to highlight that SGLT2 inhibitors, if we use 10 milligram of epagliflozin as compared to with the 25 milligram, we can achieve 80% effects of lowering glucose level and A1C reduction with a 10 milligram dose as compared to with the 25 milligram dose, where the additional 20% is enjoyed. But the weight loss is more pronounced in those patients on 25 milligram as compared to with the 80 milligram. So overall, the UKPDS data over a 42 years of experience showed that metformin is, even after a years of experience, is very safe if there is no compelling indication, contraindication to stop it. Once the eGFR is less than 45, you need to reduce the dose or half the dose, or once the eGFR is less than 30, I would recommend to stop it just to be on the safer side to prevent the lactic acidosis. So that concludes this session. If any question, any queries, I would like to ask my panelists to please to take over from here. Thank you very much for your patience listening. Thank you very much.
Is there any difference in efficacy in 10 and 25 milligram dose?
Yes, I think we have already explained that 10 milligram is covering about the 80% of the SGLT2 effect in lowering the blood sugar level. The A1C reduction is about 1.2%. The 25 is going to lower about 1.6%, but the weight loss is more pronounced in patients taking 25 milligram empagliflozin as compared to with the 10 milligram, but the A1C is almost the 80% as to the 25 milligram.
Another question is, which patient profile is best suited for different SGLT2 inhibitors?
So it was few years before, for cardiac patients, it was thought that dapagliflozin is much more better. But the recent study which we have shared now, it showed that the empagliflozin is giving you 3 to 7% additional benefits in lowering the cardiovascular morbidity and mortality in 3-point MACE as compared to with the declared TIMIC trial. So, and in the kidney trials, we have clearly seen the empagliflozin is winner. So among the different SGLT2 inhibitors, depending on the trials, I would recommend that empagliflozin seems to be a bit more superior than their counterparts.
Oh my. Just
my question is, we are experiencing a dip in eGFR in the first initial 3 to 4 weeks, but some patients are going to other after this study, after we decrease the dose.
take 2 to 3.
Are you noticing this one that there is a dip in eGFR? So, or what about to reduce the dose, or to just continue the same dose, or we'll see that after 8 weeks or after 6 weeks?
Yes,
It's
very
quite
nice.
noticeable.
Very nice. If we are going to start SGLT2, I think we need to start with the low dose. And if the GFR is below 20, we don't need to start it. If it is between 45 and between 20, we need to start with the low dose. And then we need to monitoring renal functions. After 1 to 2 weeks time, we need to tell our patient they need to drink more water if there is no compelling contraindication to drink that. If the patient is taking diuretics, we need to reduce the dose of diuretics with that. If there is no global consensus on that yet, but if the eGFR is declining more than 25%, then you need to really worry about it. Less than that, you need to monitor it. Start with the low dose, go slow, and then build the dose depending on the renal profile. So we need to tell our patients, don't need to panic. If there is 5 to 10% increase in eGFR, initially there is decline. That is usually within 6 to 8 weeks time. It is usually returns to their baseline, and then the doubling time of declining in eGFR in those patients with SGLT2 is much more longer than those patients not taking SGLT2 inhibitors. So we need to explain these things to our patients so they do not get panic. And also, we need to readjust the doses, the medicines patient is already taking, especially diuretics, in hot summer humid climates.
So I have a question. So Sohail Anjum?
We are really sorry
In
because
the
of
interest
the
of time, I
because,
think we
huh.
need just final conclusion from you, sir. Final conclusion from you, sir.
Can you come?
So we can ask questions later on as well, because.
Sohail Anjum, sir, you did talk about the combination therapies like DPP4, SGLT2 or GLP. So sometimes triple regime also you are using in your patients. No? So if drug is not working, even in the cardiac betterment or any A1C reduction, so is there any parameter to assess the which one drug is not working?
Which drug is not working?
Yeah.
So we are going to start with the of course with metformin, with SGLT2 inhibitors, and higher the BMI, it is better to start with GLP-1 analogs. If your patient is not affording and or the BMI is on the lower side, then you start with DPP4 inhibitors, and you need to give them a structured advice, meaning you need to give them written material about what they need to eat, how much they need to take their carbs, they need to go for daily walk and exercise. If you are unable to achieve those A1C reductions in spite of increasing the maximum potency in that group, then you need to add on the injectables. For example, insulins, early insulinization in your patients, or the GLP-1 might be the first injectable, then you need to stop DPP-4 inhibitors. Or in selected patients, in needle phobic patients, they are not willing to go for insulin, then the third generation sulfonylureas may be tried.
So why not insulin first choice instead of giving the SGLT2 or DPP4?
Very good. All those trials.
Excuse me, in the interest of time, we have to stop
Thank
it.
you, sir. Thank you.
You can have Dr. Saab
Just
is here.
a
You can
10-second answer that insulin does not statistically found to increase or the improvement in cardiovascular outcome as compared to patients taking SGLT2, GLP. If they maintain the same A1C, your patient with SGLT2 is going to enjoy the additional benefits of cardiovascular reduction, which is not seen in patients taking insulins.
Thank you, Dr. Sohail, for an excellent presentation where you started with the incidence of diabetes and the incidence of cardiovascular mortality, which is increased in the patients who are diabetic. And if they are diabetic, the patients with heart failure, they have a worse prognosis. Now, when we talk about the SGLT2 inhibitors, I would differ from what you said earlier on, that the guidelines actually mention SGLT2 inhibitors as the generic. They do not mention dapagliflozin or empagliflozin. And that is what we should actually do. The other thing is that I wanted to actually give a little bit more of a background as regards the heart failure, where in patients who have heart failure with reduced ejection fraction, this is a class 1A indication. The drug started as a drug to treat diabetes, but ended up in treating patients with heart failure with reduced ejection fraction. And then what was seen in Emperor, Preserved and Deliver, that this was the only drug which could be useful in patients with heart failure with preserved ejection fraction, with an ejection fraction till 65%. So you can actually go up across the spectrum of ejection fraction, irrespective you use SGLT2 inhibitors. The other thing is that it is a 10 milligram dose that was used in patients with heart failure. And that is what we have to do. More recently, there have been some studies regards empagliflozin in patients who have severe aortic stenosis, because empagliflozin has anti-fibrotic, anti-inflammatory, and antioxidative properties. Therefore, it actually inhibits the progression of moderate aortic stenosis to go into severe aortic stenosis. Medically, there is no drug which can have an effect upon aortic stenosis, except now it has been shown to be as SGLT2 inhibitor. Secondly, whenever there is the effect of diabetes on the cardiomyocytes, it is the anti-inflammatory effect of the SGLT2 inhibitors which has been seen to be very, very beneficial. So I think SGLT2 inhibitors, empagliflozin, dapagliflozin, these are the miracle drugs which have a benefit in patients with heart failure, with cardiac problem, as he showed in infarction also, in acute heart failure. In all cases, the SGLT2 inhibitors can be used and must be used. And in heart failure, this is the drug which should be started as early as possible because the benefits are seen immediately. And there is no up titration, there is no escalation of the dose. The dose is one, you use that, and irrespective of the fact that the patients are diabetic or not. Thank you, Dr. Sohail.
Thank you very much. Excellent.
Thank you so much, sir, for the elaborate talk and beautiful discussion by the panelists. Kindly, one reminder, use this Slido software, scan it for asking any questions for time saving. There will be prayer break. Prayer will be at 7:11 p.m. and we will restart our first scientific session at 11:20. There is pharma inauguration exhibition. Kindly join us for pharma inauguration exhibition. Thank you so much.